Good afternoon, esteemed guests, colleagues, and friends. A warm welcome to all of you to today's abstracts presentation session, Uniting Against HIV and STI. We are excited to hear from our talented presenters who will be sharing their research and ideas with us. Each presentation reflects hard work and innovation, and we look forward to engaging discussions and insightful feedback. Without further delay, I would like to take a moment to introduce our esteemed co-chairs for this session. I kindly invite Dr. Geethani Samaravira and Dr. Harishchandra Yakandavala to the panel. Dr. Geethani Samaravira is a consultant venerologist and has served at STD clinics in Kegola and Kalutara and joined the National STD AIDS Control Program in 2019, where she has since coordinated various programs areas, currently serving as the National Coordinator for HIV testing. Dr. Harishchandra Yakandavala is a public health expert graduated from the University of Peradeniya, who has served as the National HIV AIDS Awareness Program Manager at the Health Education Bureau, a UNDP HIV prevention project, and the HIV and Adolescents Program at UNICEF, as well as working with the National Youth Services Council and Ministry of Education to integrate HIV education into schools. Dr. Akandavala has also served as the medical director at FPA Sri Lanka and currently working as a freelance consultant. Our co-chair's session is over to you.
Thank you for your kind introduction. We are going to start a very important session, Uniting Against HIV and STI. We all know unity is the strength to fight against STI and HIV. So as we are already running behind the time, shall we straight away go to the first session? So our first presenter is Nisha Pujari. Nisha holds a Master of Social Work in specialization in medical and psychiatric social work and bringing over 30 years of experience in public health. She leads the HIV and AIDS portfolio from 2004 to 2015, integrating HIV services with family planning and women's economic empowerment initiatives. Currently, as the Director of Gender and Rights at FPA India headquarters, she spreadsheets program that promotes sexual and reproductive health in the gender just environment of SOGIESC group. Nisha also provides technical support to 44 FPA India branches across 18 states, focusing on gender norms, gender-based violence, and empowerment for vulnerable population. So, without further delay, I would like to invite Nisha Pujari to tell us about bringing gaps, building for future, an innovative framework for comprehensive HIV STI care in Punjabi key populations. Over to you, Nisha.
Thank you so much for the kind introduction. So, I'm going to share my experience of providing comprehensive HIV and STI care in Punjab's key populations. So, as ma'am has already introduced, I am from Family Planning Association of India, for IPPF member association. So, just to give a background about the HIV situation of India, we have 2.4 million people living with HIV in India. Although the estimated adult HIV prevalence in India has declined over the years, but now we see a increasing trend of HIV prevalence rate increasing with people who inject drug use, mostly found in northeastern states of India. So it's something around 7.17% high among this group. These groups are also more vulnerable to get hepatitis C infection, which increase their vulnerability. The other key population that we worked in this project is female sex workers. As we all know, female sex workers face disproportionate risk to HIV, and the prevalence rate among female sex workers is around 4.9%. The key contributing factors for people using injection drug is needle sharing, inconsistent condom use, limited access to harm reduction services, and high risk sexual behavior. With this intersection of injection drug use along with sex work, this behavior amplifies their risk, and especially if they are female who are using drugs and also in sex work, their vulnerability increases much more compared to other key population groups. So as I said earlier, I'm going to share my experience of Punjab, where we had 3 targeted intervention projects. In that, we worked with people who are using injection drug use, female sex workers, and MSMs. So the study purpose is to see which strategy works well for this group to increase service uptake. So basically, the sample size included 2,000 key population groups from these categories. In that, 600 were people who use injection drug use, 1,000 female sex workers, and 400 men having sex with men. So as you all know, in India, under any targeted intervention projects, the key populations served are screened for STI and HIV biannually. So every 6 months, the KPs are required to undergo HIV testing and STI. So we found that 95% of our target group had regularly attended these biannual STI and HIV screening sessions, and 1,900, nearly it is 95%, have gone for HIV testing also. So over the 3 years, we found that 7% of the targeted group were tested positive for HIV. And I would like to say that mostly these are from female sex worker category and people using injection drug use. And they were linked to ART services. 171 persons were treated for repeated STIs. Mental health counseling was regularly provided along with our HIV pre and post test counseling. Regularly, got in touch with our staff and continue to get mental health support. Condoms and clean needle syringes were regularly provided to the target group to prevent them from HIV infections. So in conclusion, I would like to say that the categories I mentioned may not be a single identity. Like, for example, a person using drugs may be living with HIV, may be in sex work. So there are multiple identities, and their vulnerability includes and increases more as they have, more than one identity. A female drug users may be into sex work, may be living with HIV, maybe as partner of a. So you cannot treat one individual as one identity. This is what we learned from implementing this project. So you need to understand the multiple intersectionalities and multiple vulnerability when you are working with the key populations. So you need to create a supportive environment, maintaining the confidentiality so that they come out with their multiple identities and vulnerabilities. We need to address the SRH issues of all the key population, especially I would say women with multiple identities, because they may be a substance users, using injection drug use, living with HIV, or maybe, into sex work. Our integrated approach is very successful, especially for this group who are highly stigmatized and discriminated based on their behavior and profession. So as a recommendation, we would suggest that the service providers should have a comprehensive understanding of intersectional vulnerabilities of all the key populations, including their SRH needs. So when you provide integrated services, I would say include information on self-care services. When I say self-care services, it includes the oral prep. Like, for example, in India, the oral prep is not known to many of the key population group. We need to, provide this information because that's the best prevention methods for the group who are negative, and it's the only one method to keep them HIV negative forever, because condom usage always depend on the male partner. Similarly, when a woman in sex work may be living with HIV or maybe using drugs, should know the different contraceptive methods too, because the negotiating decision making power may be less with female, because many a time, because of paying more money by the the partners or the customers, women may not use the contraceptive. Most of the time she may land in unwanted pregnancies. So there are discreetly used contraceptive methods such as injectables, oral contraceptives. These are there. We need to provide that where she can use these contraceptives discreetly without knowing, informing the partner, and she can avoid the unwanted pregnancy. This should be done in a non-judgmental, stigma-free, supportive environment. And as I said, mental health support is coming up again and again, and this is not being, incorporated strongly in any of the interventions. All the key populations have a lot of mental health issues, depression, suicidal tendencies are there, because of their vulnerability, and to keep supporting their family or the children or to support themselves, they do, with knowingly they get into the risky behaviors. So a lot of mental health support needs to be given as a service provider so that they will cope with the mental stress. Another thing, including the rehabilitation for injection drug users, ART centers, skilling. I would suggest that employable skills to be, provided to the key population group so their dependency on sex work will be reduced. Lastly, advocacy effort on policies that recognize and address the multifaceted challenges faced by the KPs needs to be strongly advocated. I think with this presentation, I would like to thank everyone for your patience hearing. Thank you.
I'm presenting the second abstract presenter, Dr. Hamindika Saparamadu, and his abstract is on eliminating vertically transmitted HIV and syphilis in Sri Lanka, the role of social determinants of health. Dr. Saparamadu, he is having MBBS, MPH, postgraduate diploma in health economics. He is a public health professional with advanced training in epidemiology and biostatistics from the Johns Hopkins Bloomberg Social School of Public Health. He is a member of Delta Omega Public Health Honorary Society and has completed the Health Policy Institute Fellowship at the Maryland General Assembly, recognized as one of the 20 under 40 Sum of Health Promoters Finest by the American Journal of Health Promotion. Dr. Saparamadu has also received many awards for excellence in U.S. public health practice. He currently serves as a research associate at Johns Hopkins Medicine. Dr. Saparamadu, so over to you.
Thank you very much for the lovely introduction. Good afternoon, everyone. So we are here to talk about dual elimination, or vertical transmission, dual elimination, the story of dual elimination in Sri Lanka, the success story as of 2019, and how social determinants of health play a role in this story. So my name is Samandika. I'm presenting the work done both of me and my colleague, Nimasha Fernando, and here are our affiliations as well as our contact details. We have no conflicts of interest to declare. And thank you very much. We want to first of all thank the organizing staff and the session chairs, as well as especially the reviewers for the wonderful comments to improve the quality of our work. So this is we'll start with the usual story. We'll start with the general objective. So we wanted to identify the social determinants of health that contributed to the successful elimination of mother-to-child transmission of HIV and syphilis, or dual elimination in Sri Lanka in 2019. I want you to focus on the specifics here. So first, to identify a comprehensive list of things that contributed to the success story. And then we wanted to develop an evidence-based and experience-informed framework to understand how this elimination process might work in our local context. There are some applications, practical applications, but we'll talk about it towards the end. So this is a systematic review. To start with, since I'm a person who's not in HIV, so in case you're wondering, so my expertise are mostly in non-communicable diseases, and my contributions were from the social determinants, whereas my colleague is in global health in HIV with PEPFAR funds working in Africa. We wanted to first of all identify what were the key determinants in this story. We drew our professional experiences. We'll get to that later very briefly. So we wanted to get everything in together to understand what is our approach as well as how we are going to strategize our search. So if you can focus here, we wanted to create the search strategies, and we used the PCOS method and the mesh terms, the usual, the keywords as well as operators across all the databases listed here: Cochrane, PubMed, Scopus, Web of Science, and Google Scholar. Google Scholar for Grey literature, and included all the literature from 1995, English literature, and HIV and syphilis, vertical transmitted related, specific to Sri Lanka. When we created a data extraction tool to make it more systematic and to make sure that we are not going to lose any piece of information in the story. So we had, in the initial version, we had 117 determinants listed based on 4 frameworks from the literature. We'll get to that in a minute. So if you can focus on the center, you can see the center left is the final form. This is the Commission on Social Determinants of Health framework developed by the WHO. And the second one is identified drivers of HIV-related inequalities. This is a USC 2022 paper, but this was informed based on the seminal paper by Dahlgren and Whitehead, early 1990s. Additionally, we also included the socio-ecological framework for prevention of mother-to-child transmission, as well as some of our own work from 2021, exploring how COVID-19 affects the low-wage migrant workers in Singapore, Brazil, South Korea. So this is the initial version we had, just for the information as well as for the sake of completeness. Once we have the data extraction tool, we completed and compiled a comprehensive list, analyzed and organized the data, and finally refined through an iterative process to figure out and rather to develop the final framework. This is the first figure or the flowchart. So we started with 401 sources identified from the databases as well as from Google Scholar. We had 638 results. For full text review, we had 28. And in the final analysis, we had 8 papers, and we identified 38 unique social determinants that may have contributed to the successful dual elimination in Sri Lanka in 2019. So these are different few ways of looking at the results. These are all the 8 papers. I'm not sure, maybe the authors are here. So if you notice anything that we may have missed, please reach out to us, especially any grey literature that we may have missed, because we want to continue to work with the stakeholders and who actually worked on the ground to complete this research and before publication. The important thing is the 5 papers that had mentioned the most number of social determinants and explained how they had influenced the success story in Sri Lanka were all from grey literature. They're all from Google Scholar. So just to highlight how important it is to look for Google Scholar for topics like these. This is another way of looking at it. I think if you can focus on the bold black text on the left side, so you can see these are the 10 most frequently mentioned social determinants. So all of them are mid and upstream determinants. So that's we thought it's a very important thing to notice. The reason being, even when you look at the frameworks developed by the WHO, most of the emphasis is on the political factors and the health systems, delivery of care, etc. It's not more about the downstream determinants. So that we thought is an important thing to notice. We'll get to that later, why it is important. And I'll move on to the more important things. So these were all the determinants that we have developed, identified from the literature. And if you can, this is a very busy slide. We'll try to focus into more specifics. So the blue bold text represents all the determinants that have been cited by at least 3 or more authors or 3 or more papers. As you can see, all of them are mid to upstream determinants. You can see the healthcare services, health system financing, workforce, medical products and technology. So these includes the testing facilities and the service delivery. The same goes to more upstream determinants as well. But again, we labeled as mid-upstream because there's some difficulties labeling exactly which is upstream and which is midstream. So we try to treat them as liberal as possible. Again, the same trends. Often more of the emphasis has been around, like for instance, global organizations, international agencies like WHO, the Southeast Asian Regional Office, public policies, antiretroviral therapy drug supply, and health systems and infrastructure. So based on all the information we have in hand, so then we went through a week-long iterative process of finding out how exactly these things interact with each other to bring the outcomes that we wanted, which is prevention of HIV and syphilis in an infant. So this is the framework that we have in hand now. As I said earlier, we want to work with the actual people who worked on the ground to see how else to tweak this, to find out like the real picture on the ground. So there's much more work to be completed to do before we go ahead with the publication. I want you to just take a look at the top of the figure. So we are talking from left to right. On the left corner, you have the upstream determinants, and the right corner, you have downstream. So we are going to go from left to right. I'm not going to go into detail because our time is very limited. So we'll just focus on a few interesting things. The center, we have things that are directly related to dual elimination. Because when you read the terms, for instance, political support, private corporations, like how private clinics and hospitals can support in this process, and international organizations, leadership and governance, they seem very, very, very generic and broad. But interestingly, all of them had very specific role in dual elimination pathway, like what they have to do exactly to support, perhaps to identify cases of HIV and syphilis, or initiate treatment, or to referral, etc., etc. So those things on the left corner, things can feed into things like funding, guideline development, and improvement to existing healthcare systems. Like for instance, in 2013, when Sri Lanka first pledged to eliminate dual elimination, and by 2014, I think they were already on it. And the Western Province, Central and Southern provinces were starting the program. And in another year, they developed the circulars, and all the provinces were completed with access to HIV and syphilis testing during the pregnancy, improving the testing rates up to about 90-95%. So that was remarkable. And that's the service delivery part, how all these things feed into service delivery, distribution of services, and healthcare manpower, how they improved, and testing facilities improved. So that feeds into basically access to care, and access to care has a lot to do with individual level things, like how an individual can access to care at a very personal level. So here I just want you to focus on this area. The reason being, there was one case study that we found, a lady from Jaffna who was diagnosed with HIV, but her family was tested first positive for HIV in India. A little bit of a loss to follow up for a while. And however, she was lucky to have a healthy baby with a HIV negative baby. So the interesting thing is, because that also emphasizes how the regional healthcare systems can play a role in this story, but we did not include as a determinant, reason being that is a bit out of scope of our research question. But that's something that we also want to explore further. On the right lower corner, so this is the ultimate outcome, which is the prevention of HIV and syphilis in an infant. So as you can see, there are key 3 pathways that leads to this outcome. So on one hand, we have preventive. So the ability to practice preventive measures can feed into the final outcome. At the same time, once you have diagnosed, having early treatment as well as specific delivery, like for instance, cesarean section for delivery, can lead to, again, a healthy baby. And again, through access to care as well as through knowledge and awareness through campaigns, safe breastfeeding practices can also play a role. There's another interesting story to this, but that was not mentioned in any of the papers, which is access to a formula milk. But that's another important determinant, but that complicates this whole story. So we did not include it at this point in time, but we want to explore that further as well. In conclusion, varied social determinants of health contributed to the successful dual elimination of HIV and syphilis in Sri Lanka, but most of them, like more than 75% of them, were clearly mid to upstream determinants. And there is a notable gap in the literature exploring the influence of downstream determinants, despite these factors may have actually been considered. And why is it important? Because, as you know, these are infectious diseases. Again, as I said, not my focus area, but when infectious diseases, even including the infectious disease of poverty, when you break it down into social determinants, often things there are a lot of overlaps. So there are a lot of cross-cutting indicators that can be easily leveraged to do a lot of proactive work. So instead of, for instance, like this story started from 1954 originally, and then 2002, the first prevention of mother-to-child transmission in Sri Lanka, HIV transmission. And then there's a long story from 2009 and 2013, but there's always a way to incorporate a lot of things through different agencies. So I think that will be a very interesting way to look at it. It is not usually looked at that way. So that's something we wanted to emphasize. And as one of the recommendations is the programs in Sri Lanka should prioritize understanding, documenting, and publishing how various determinants influence their outcomes with a focus on downstream determinants. And then other low and middle income countries, I think so far only 3 countries have eliminated. I think Thailand, Sri Lanka, and Maldives, if I'm not wrong. And these could be leveraged, especially to identify what kind of strengths they have. So at the same time, when they use WHO guidelines and WHO frameworks, they can also take a look at how social determinants of health work. If they have, for instance, a very strong awareness campaign, they can leverage on those things first while waiting for funding and other mechanisms to take place. So just a different ways of looking at this issue and infectious diseases in general. And that brings us to the end. Happy to take any questions at the end. Thank you very much.
Thank you, Dr. Saparamadu, for your very exciting presentation.
So our next presenter will be Praveen Sonna. She will be talking about understanding the needs and experience of transgender individuals, a mixed method study of the Pune branch of integrated services. Praveen Sonna, also known as Purvi, is a development sector professional with over 18 years of experience in health, family planning, HIV/AIDS, and RMNCH+. They hold a master degree in social work and specialize in safe abortion services and comprehensive sexuality education. Praveen is a member of various committees in educational institutions, has presented at national and international forums, including ICFP 2022. As LGBTQIA activists, they are dedicated to empowering vulnerable communities and were a founder of India's first transgender dual Tasha Pata Shikandi. Over to you, Praveen. Sorry if I mispronounce any of your names.
Thank you so much for the lovely introduction. And I'm used to for that mispronunciations because we, the LGBTQI community, we are into a fluid gender sexuality as well. Okay, so majority times our pronouns are mispronounced, but we are okay with that only because everybody is in learning stage. Okay, so I go with the pronouns of he, she, and they, and I identify myself as a queer trans person. And there are so many other several categories which people are yet to understand and learn as well. So with that, we will start with the presentation. In my presentation, along with the other things, the background is also very, very important. This is a study from FPA India, Pune. We have a clinic in Pune, and the background of the program is very interesting. As I said, that unlike other like other South Asian countries, India also have a lot of challenges in accessing comprehensive services when it comes to transgenders, and that too mainly gender affirming services. And all the barriers are stemmed from deeply rooted societal stigma, discrimination, lack of healthcare providers, and also knowledge around it. So that's the main barrier. And all these barriers come to one path or one place wherein you can see a lot of discriminations at the service providers level, which transgender community is also facing. Okay, not only in India, but I was also studying about Sri Lanka. Everywhere the situation is same, and these barriers are resulting into something very, very vicious or something very dangerous for the community itself. One thing is, because of these barriers, there are private practitioners, those who are privately practicing, knowing and having the good knowledge, but they are minting the money out of it. That is the first thing, because the services which are provided by them are at really, really high cost. One. Secondly, they are not following any of the guidelines. In the previous time, there were no guidelines, but recent times we have WPATH guidelines, IPATH guidelines, but those guidelines are also not followed by those private practitioners. So pre and post care is not at all available. Only the mid care during the surgery or the therapy, those cares are available, but pre and post, there is nothing available. At the same time, these are only available in urban setups, not in rural setups. So all transgender community have to go to those setups and they cannot access it unless they have a lot of money. And majority of my sisters, my brothers are forced to get into sex work in order to get those surgeries. Do we agree with that? Of course, all of us. Either you have to be born rich or you have to shell your body to get things get done on your body. That's the first thing. Secondly, because of this, there are along with this, there are other problems as well. There are no other healthcare providers, those who can provide, there are no specialized healthcare providers in public settings. That is one thing. Secondly, the knowledge about the services is not much with the community and the service providers. At the same time, the scarcity of facilities, specialized expertise, and high cost also pushes all the transgenders to a dangerous situation. And many a times, as a result of this, majority of them go for self-medication, especially in hormonal therapy. And self-medication is a very dangerous situation because it can lead to many issues like cardiovascular issues, liver problems. Then they can have some cancers because of imbalance of, they are prone to get some cancers because of imbalance of hormones, and also bone density goes low. So there has to be a medical expert who is looking at that transgender when they are medicating. So that's the main problem when it comes to transgenders, those who are accessing hormonal therapy by themselves. All these things are very, very dangerous for transgender community. But as I said, that having lack of resources, money constraint, they are pushed to have things on their own. And majority times, if at all something is prescribed to me, my other 10 friends will come to me and will always opt for that without going for LFT, RFT. Those are the things which they are supposed to go in the beginning. That's the reason the background is very, very important. FP India Pune branch is serving LGBTQI community since 2008. And since then, we are working for HIV prevention, STI prevention, and treatments referrals. During the pandemic, many transgenders approached us for seeking help in terms of dry ration kits because they couldn't beg, they couldn't do sex work at that time. And that's the reason they requested. That was the time when they requested, they started coming to our clinic. Prior to that, we were going to them through mobile clinic vans. But at that time, they started coming to our clinic to collect those rations. And that time we had one form. It was a baseline survey. So we collected data and we asked their unmet needs or needs, demands, what they want. And that time they said that we would like to have services under one roof. And that's how this clinic has come up. This clinic, we call this clinic as one window approach. And that's a clinic wherein we are having several services. Based on the service accesses, we have done the study, and the objective of the study to document the range and volume of services like HIV testing, STI testing, NCD screening, and also gender affirming services like laser hair reduction and hormonal therapy. Second objective was to evaluate the client satisfaction and their feedbacks to improve. Third one was assess the effectiveness of one window. That was the approach we started with, but right now we have a clinic, and that's a very, very interesting and integrated model, and to identify challenges and areas to improvement, because whatever we started, just trial, but we have continued from 2020 till 2024 now. In methodology, 750 transgenders are interviewed. It's a client data record. We have several documents wherein client data records are there. Then the data triangulation was done. At the same time, we had a qualitative survey. We had feedback surveys. We had client exit interviews. All these things are inculcated in this complete research. Local ethical committee suggested that we should not exceed than 750. Previously, when we started with baseline, we had only 650 transgenders, those who came for baseline or collect the ration kit. But over the period of 4 years now, we have more than 900 transgenders those who are accessing services. Special attention, 45 transgenders have given their interviews about the services, about the service accessibility, and how friendly or how inclusive the clinic is. Result section talks about many more things than that of whatever is depicted here. If at all we are interested in understanding the success stories. Then the success stories are like majority of them have undergone laser hair reduction. All the 750 transgenders which I mentioned, they are the transgenders. They came to our clinic, and when they were accessing services or after accessing services, the data was collected. So all the 750 transgenders have undergone laser hair therapy at least once and more than 3 times as well. Up to 85% of them have gone up to 3 times of services. Then we have TGs, those who are, if you see the demographic, 80% of them are into begging and sex work. So you can imagine what kind of amount they must be making. Our aim for the clinic was to cost or to charge a minimal amount of service charges so that they can access it and come back to us. There are private practitioners, those who are charging the same service for 5,000 rupees, and we are charging only 700 rupees for the same service in order to have a cost recovery basis, because we received a funding for a year from IPPF, and that's how we started the clinic. But after 1 year, we cannot stop the services, no? So for that, we started. So if you see, 18 to 55 was the age, and mostly transgenders were below 29 years. Education, if you see, 85% of them were either literate up to HSC they have studied, but 15% plus people were postgraduate and graduates. So that's also a very remarkable thing which we noticed, that many of them are graduate and postgraduate as well. SRH services, of course, there were other services which were improving with the time. HIV services have gone up, even STI services have gone up. The linkages of positive people were also gone up. At the same time, in Pune, there are some other 4 organizations, those who are working for transgenders and other communities. We are not ought to give HIV and STI services, but still they are accessing those services at our center. That was one thing. At the same time, we have hormonal therapy. 45 plus transgenders are undergoing hormonal therapy. We have a visiting consultant who comes to our center, and we are giving referrals to GID certificate, gender certificate. Along with that, with the process, we understood that there are some other demands from the community. They want entrepreneurship trainings. They want to go for higher education. They also wanted some employability factors. So we also placed some transgenders, like 12 trans women and 6 trans men, to the local government security guard department. And that was a big success for our complete team. Is there any way we can place these videos? These are the videos which you were mentioning. That's India's or rather world's first Dhol Tasha Pathak. Dhol Tasha is a group of musicians. Drums are played. That's a tradition of Maharashtra. And till now, men and women were playing. And with this clinic, we also have some small group through which we started this Pathak. So if at all, we can play that video. It's just a 30-second video, if possible. Is that possible? The integration of services along with SRH and the other gender affirming services results in a really, really good thing. We have seen people changing their lives, and actually our aim has to be not only to provide the services, mainly if at all anybody of you want to start such kind of clinic or want to have inputs, you can connect us virtually or you can visit our clinic. The main important thing is always train your staff to have an inclusive environment. It is not easy. Sitting in a room talking about it, it's very easy. But when it comes to reality, when we are having providing services at SRH clinic, women are sitting and one transgender walks in, they don't like it. They either don't like it or they make a point that next time they are not coming. So we have to have a balance of both. Also, our staff, how they behave. If you train them well, they will be more friendly. They will be too friendly. That is also not good. If you have to train them to have an inclusive environment, we have to have a balance. That's what the takeaway from this entire thing. And these are the recommendations. These are few, this is how the laser therapy works. These are our TGs, those who are excellently doing well in food industry. And she is a very good makeup artist. She is an artist for one of the leading actress. We also have one transgender who is proudly known as a porn artist beneficiary. She is very well known porn artist. And that was a question from one of the presenters last time, why a porn artist name is given. But of course, that's also a profession. We cannot leave, I cannot leave this stage before, thanking these people, each beneficiary, all the staff, IPPF for giving small grant. But of course, the first step is the most important step. All the donors and all the listeners, all the panelists, and at the same time, chair and co-chair. Thank you so much.
Thank you very much, Purvi.
The fourth abstract will be present by 2 people. without taking much time, this is for you and you can present your paper. Kavihari and Kalara Pereira.
Good afternoon, everyone. I'm Kalara Pereira, and this is my friend Ravihari Ravindra Kumar. So this is our topic. To briefly introduce why we selected this topic, it's because nowadays we see a lot of young people using digital platforms to sort of get information as like a source of information. And what we realize is that unlike very traditional settings, like if you're getting information from maybe your parents or your school or whatever other programs, they stick to very specific subject areas. So sometimes sexual and reproductive health does not necessarily limit itself to childbirth or menstruation. It's something much more. So in that sense, things like exploring your sexual orientation or sexual pleasure, things like that, young people usually tend to look through it through social media. And in that sense, is social media influencers have found their role in that platform where they are able to sort of provide the answers in a very relatable manner. And they are also, when they try to give up this message, they are also having this sort of barriers, these cultural barriers, and also these other limitations, but they are also engaging and trying to sort of engaged in this discourse on sexual and reproductive health. This comes to our objective, which is basically the study aims to explore how social media influencers create content focusing on sexual and reproductive health as a means of engaging social media users in the broad discourse on SRH with emphasis on the South Asian context is what we are looking at. So the methodology, this is a sociological research. It's completely based on qualitative data. We did a manual content analysis. What we did was we basically went through our literature and we came up with a couple of keywords, and we used those keywords and manually entered it on the specific social media platform that we selected, which was Instagram. So we selected Instagram because a lot of young people tend to use Instagram, and from Instagram we manually entered the keywords and we got a list of people, and from those people that we selected, we connected with other people on the same list, and we came up with like a pool of 10 people. And of course, this is a purposive sampling, and through and also the influencers that we selected, we made sure that they are from like from South Asia. But unfortunately, most of the influencers that we found were from India or Indians living outside of India. So, and with this is our literature review. So for literature, what we figured out was the fact that there is literature on social media influencers, how their expertise on commercializing a sort of product, but not so much on how much effective they have been on raising awareness on like a public health policy sort of avenue. And most of it was not in the South Asian contents. Actually, we couldn't find anything related to South Asia and how social media influencers are raising influence on that. So with this, I'll hand it over to my colleague Ravihari.
So basically, I will go through our results, the results of our study. One of the things that we noticed was that incorporating multidimensional narratives is very important, but it's crucial to understand that engagement doesn't always mean that there is effective information dissemination also, especially when it comes to sensitive topics with regards to sexual and reproductive health. For instance, one of the interesting things we noticed was that there was a variety in technique, especially there's a lot of humorous skits, etc., that are used to disseminate this information. But one of the things that we noticed was that such content can be reliable in some instances, but could also risk trivializing certain serious issues. It should be handled rather delicately. So while variety is important to ensure that content remains accurate, respectful, and educational, it is important to draw a boundary with regards to information dissemination via social media. Another thing we noticed was expertise caution. Most medical professionals, we noticed, who were SMIs, discuss certain subjects in order to sidestep legal or ethical complications. So basically, they don't give medical advice on Instagram. Although influencers still offer, however, valuable and insightful conversations about their personal experiences or promoting expert resources, etc., rather than positioning themselves as authorities. That's something we noticed. And we also notice that intersectionality and the lack thereof that leads to a homogeneity of subject matter in the content that is created is important to note, especially youth, individuals from the LGBTQIA plus communities, and those from certain socioeconomic backgrounds often face unique SR challenges as opposed to other communities. And by failing to address these specific issues, influencers may inadvertently alienate these groups and provide information that focus on a homogeneous group of people as opposed to looking at more diverse groups of individuals. The other thing we noticed was that influencers might tailor their content to what they believe is a potential group of individuals to whom their content is created, but that might also lead to them avoiding controversial topics, and because of the fear of backlash, etc., they might not talk about more important things. Another thing we noticed was that there was a very rigid medical versus non-medical binary. So medical health professionals on Instagram creating awareness on very traditional and conventional topics, and then there are non-medical influencers, so to speak, who talk about more non-traditional conversations such as sexual pleasure, sexuality, sexual orientation, etc. So that's something we noticed, and we thought that bridging that gap is very important. And content creators and audiences and the audience engagement was something we also looked at, which largely remained within the gendered framework. So we noticed, and I don't want to make generalizations, but largely men tend to respond to certain topics like sexuality and sexual pleasure a little bit negatively than women audiences. That's something we noticed. And women, on the other hand, they thought that some of the content was very empowering and that it talked about establishing a safe space for women to talk about their sexuality and talk about the concerns that they have in safe spaces. So that's something we noticed. So our conclusion is basically that social media influencers play a huge role in destigmatizing female sexuality and talking about certain topics. But however, we notice that certain topics are largely still left undiscussed, and that's something that needs to be addressed. One of the limitations of our study was that even though it says South Asian, we are looking at the South Asian demography, we couldn't actually look at it because there are no Sri Lankan influencers as such, or Bangladeshi influencers, or Pakistani influencers that we could find with a big outreach who talk exclusively about sexual and reproductive health. So these are our recommendations basically. So advocating policy initiatives and encouraging individuals from other geographical regions and within the geographical region from other countries to talk about their concerns and to talk about sexual and reproductive health, and to engage with influencers from different backgrounds, gender identities, to enhance representation and inclusivity, etc. And we've also mentioned that incorporating evidence-based resources is very important. So we noticed that some of the social media influencers also collaborate with medical experts, which is also very useful. And it has to be a very interesting and nice collaboration between medical and social and people from basically various professions and various backgrounds, especially professional backgrounds. It could be different socioeconomic backgrounds who talk about these things openly and engage in conversations that include everybody as opposed to certain people only. So that's something that we would like to conclude on. Thank you very much.
So thank you very much for both for presenting very interesting paper.
So we are going to have our last presentation today by Abhishek Pratap Sen on sexual and reproductive health inequalities faced by the transgender youth, transgender men and trans men. Abhishek is a highly skilled community mobilizer and sexual health counselor with experience in outreaching, education, counseling. He has a proven ability to build rapport with diverse groups, deliver engaging workshops, and provide confidential counseling on a wide range of sexual health topics. Over to you, Abhishek. He will be presenting online.
Hello everyone, my name is Abhishek and I work as a virtual counselor at Humsafar Trust in Delhi, that is in India. Today I'll be going to present my research on sexual and reproductive health inequity faced by transgender youth, that is trans women and trans men specifically in India. And my co-author, Mr. Murugesh, really helped me in writing this work, and he is working as a chief operating officer at the Syphilis Trust as well. So to begin, with the presentation, I would like to mention that young transgender individuals, that is trans women and trans men, often have limited access to SRHR services in India. Being a trans individual, I have also faced these challenges, and this is something which is also very personal to me. And given that the promotion of human rights to youth-friendly care is there, that is implemented in India, but it has an impact on the ability of specifically transgender communities to access SRHS services, that is HIV, STD prevention or care. Moreover, stigma and discrimination is often faced by transgender communities, by healthcare professionals, and that also works as a major barrier to accessing SRHS services. Also, young individuals are particularly concerned about their identity to be disclosed and sexual practices to be discussed in detail by healthcare providers, majorly because the healthcare providers are not that much sensitized or even aware to actually understand these. So the objectives of the study was that we implemented a virtual SRHR intervention for the population, and we also reviewed available content, evidences of barriers to services for youth transgender individuals to provide recommendations on expanding strategies to improve access to HIV/STD prevention and also care within this population. The experiences of implementing a complete virtual intervention, including a comprehensive risk assessment tool, provided contextual understanding by barriers to services, successful outreach, and also service delivery mechanisms to the population for increasing access to HIV and other allied services. So the methods that we used was that Humsafar Trust, which is the first community-based organization in India, is as of now implementing a global fund supportive HIV prevention and treatment services linkages intervention, which is commonly known as NetReach. Through NetReach, we are able to expand services virtually to a large population in India. Though the outreach to key and affected population is done completely on virtual mode, a comprehensive assessment of the risk and vulnerabilities is facilitated through NetReach on a virtual platform for community individuals to facilitate self-assessment and also increase overall health-seeking behavior in long run. The prevention model is designed to complement the first 90, that is increasing testing of unreached population of the global UNAIDS goals, which is also an integral part of NACO and also NACP, that is National AIDS Control Program, Government of India. NetReach virtual outreach strategies have been designed considering privacy and autonomy of vulnerable populations. A platform has been developed which facilitates HIV risk assessment through NetReach and also connects clients with a range of services delivered at government and private facilities. Community-led outreach strategies use different social media and dating platforms to share HIV prevention and service information, majorly known as Grindr, Twitter, Bumble, and all these platforms which are majorly used. Assessment indicators on virtual platforms include condom usage practices, sexual partners, presence of STIs, engagement in commercial sex, usage of chemical, other stimulants during sexual acts, commonly known as drugs, and needle and syringe sharing practices, which is very prevalent among transgender community in India. So, as per NetReach data from April 2021 to March 2024, only 889 young transgender identified individuals that were between 18 to 24 years were reached to the program using virtual platforms and dating applications. When this is compared to the other key and affected population groups such as men who have sex with men, that is commonly known as MSM, female sex workers, that is FSW, and drug users, there is a vast difference in outreach itself, which is 49,280, which comes as a quite shock. Of the total reached 889, only 132 individuals, that is 14.8% to be specific, conducted the risk assessment, whereas the risk assessment was conducted by 15,999 individuals, that is 32.2%, in other groups, that is MSM, FSW, and drug users. HIV reactivity rate among young transgender individuals was found to be 5.5% compared to 3.3% among others. So, to conclude, while the youth transgender identified individuals are at a higher risk of sexually transmitted infections such as HIV, among others, the available literature and our experiences of implementing the NetReach interventions suggest a much lower self-perceived risk, lower health-seeking behavior, and engagement in multiple risk factors such as drug use and sex work, which was very prevalent. Mental health conditions of the population in the gray age group is also severe due to gender incongruence. Lack of sex education and also physical changes coupled with gender identity related issues fuel mental and physical health issues among transgender individuals in India. Moreover, stigma and discrimination phase in different settings, majorly family, education institutions, healthcare facilities, further pushes them away from accessing SRHR services. So, to recommend, it is majorly important to address challenges that are related to SRHR among youth transgender population, which needs a multi-pronged strategy. The strategies majorly would include policy, legal reforms, that is advocacy for the protection of rights to SRHR services that are free from discrimination for transgender individuals, youth-friendly healthcare services, that is developing a culturally competent, inclusive, affirming healthcare environment for gender non-conforming adolescents. Moreover, Unity works in diversity majorly, that is implementing comprehensive, accurate, age-appropriate sex education programs that are inclusive and address the needs of transgender youth in India specifically. Moreover, community engagement is highly crucial as mobilizing transgender communities through support groups and also peer support networks and capacitating them as advocates would also help in building second-line leaderships. HIV STD prevention, the promotion of HIV and STD testing, treatment and prevention programs that are very accessible and also affordable for transgender youth individuals. In doing so, they will also promote thriving and health among one of the most vulnerable communities in our society, that is by multi-level reductions in barriers to SRHR services for youth transgender population that disproportionately experience HIV and STD burden. So, when we often talk about SRHR, the SRHRJ, that is justice, is often missing. So, when we talk about sexual and reproductive health and rights for transgender individuals, often also important how legal and policy reforms can also help in providing justice to the individuals who often face these barriers. To conclude, these are the references which really helped me in compiling my abstract specifically, which is the NetReach website. And it would be great if you guys can maybe, folks can go and maybe see how we are working through this Global Fund project and providing virtual services to the community in India. Then another organizational website and also NACO specifically. And to end it, I would like to thank Repro 6 and also the organizing committee for giving me this platform to present my work. And I would just like to say my voice and my rights. Thank you so much.
So we will have 2 minutes for your questions and answers. Nisha Pujari. So I have one question for you, Nisha. You mentioned that in your program you screened them for HIV and STI. So what particular STIs were screened?
It's normally for syndromic, screening. Yeah. And HIV testing. It's a community-based program. So in the outreach, the team goes and they screen for STI, syndromic.
Okay, it's
and,
just the symptom
yes,
screening.
and the HIV testing. And if there are, found anything, then they would be referred to the government hospital.
Any other questions? Thank you very much.
Okay, the next is from the second presenter, Dr. Sapramadu. If you have any questions from Dr. Sapramadu, please ask your question.
So, in the
Sapramadu, there is no questions to ask. Yes.
third speaker is Purvi. Yes, Purvi. So, any questions from Purvi regarding the presentation on understanding the needs and experience of transgender individuals, a mixed method study of Pune branch?
Thank you so much, Purvi. It was a very informative presentation. I wanted to ask you, you mentioned pre and post care it's still not available, and your clinic is providing it now. So how are you managing the cost? Because you got the funding for 1 year, and what are the better ways to manage the cost after the funding ends, or if the funding is not sufficient? Because I am also trying that to do in Pakistan, so it will really be helpful.
Question from a sister to a sister. Thank you, sister country, sister sitting next to me. Thank you so much. There are two questions. The first thing is that are we offering pre and post surgery consultations and counseling as well? As of now, we are not having that service with us. Okay, but wherever the services are happening, we are trying to make that at least our team can go and assist them, because there is one very well-known private clinic set up in Pune which is offering these services for last 40 years. WPATH guidelines have come 10 years ago or 15 years ago, but that clinic is known for Nirvani and the other castration services. That clinic is known, but they do not follow any services. We are trying. We had like 3 meetings with them, trying that they should start those following those regulations. At least they are not, at least like they are not doing it, but we are trying. Okay, so we have not stopped it. And there is one medical hospital, bigger hospital, Bharati Hospital. We have tied up with them, and so pre and post care counselings are done there. So there is no money involved in that. First thing. Second thing is that always for having such kind of projects, it will come on a project basis. So you have to have a vision of running that clinic after 5 years, 10 years as well. So sustainability can come from cost recovery basis, that we are charging 700 rupees, which is a very, very less amount. But of course, that amount can be used for refurbishing the thing. And there are some other ways of local fundings as well. Like CSRs are also coming forward to support LGBTQI community initiatives. It's in very minuscule level, but we have to go to 10 doors. Only one door will open after that. So that's the only thing. And we always have to have that sustainable thing in your mind.
Thank you very much, Purvi. I
Yeah.
think I should congratulate you on your great work, because it's a very good initiative. I mean, that is what the community strengthening means, isn't it? And the strength and the building capacity of the community is very important. Do anybody provide you technical support to train your staff and all that? Because these transgender services involve a lot of technical specialities as well.
So technical support was given by IPPF for some time being, one. Secondly, HQ is always there to support us, because wherever we are lacking, we ask to headquarters of FP India, and they directly come up with a solution, at least in a primitive level. Because so if at all we were seeking for hormonal therapy treatment guidelines, we had no guidelines with us. But overnight, she contacted one of the experts, and that's how we created smaller level guidelines. But at least we could start the work. That was
Simpler.
one. Yeah. Simpler format. And at the same time, when you start working, there are some other people, like my doctor who is providing hormonal treatment. She is working with some other competitive organization, but she is serving as a doctor at our clinic, because we are like, there are so many clients those who are coming to my clinic rather than those clinics. So she agreed to help us, and she's still with us, although she is working on a very big post on that organization, like at that organization, but still she's working with us. And if at all she cannot come, she creates a pool of experts, those who can come and help us. So that's how, like, once you start working, people will come to help you, if at all you go with your dedication 110%.
To add, we have also how SRH providers can provide gender reformation services, information, and referrals to the community. So our staff are trained. If a person from the trans community comes, how to counsel them. How to help them. To understand their identity, or whether they really wanted to go for a gender reformation services. Those things are there. Along with that, there are other things are also, like changing the name. So we have developed the guidelines with the help of experts. So that gives entire, trans people needs to a SRH service providers. So it is easy for a SRH service providers when the community members come to our clinic to provide this information. Of course, we have a strong referral, as Purvi said, with other organizations, because we are a SRH organization. We can provide a good counseling information, along with the partnership with others for their other gender related services. So these are the guidelines. If anybody is interested, please write to us. We can share the soft copy of that.
In a way, Sri Lanka is fortunate that we have government-funded psychiatric clinics providing the transgender services, and also endocrinologists providing the hormonal care as well. But I know that the services are limited, and they have to sometimes wait in the waiting list.
We can say
Restrictions are
services
there.
are too limited. very much limited because the hormonal therapy is yet to start in Sri Lanka full-fledgedly. Whatever the drugs are available right now, I would urge that the government should pay attention, because in one of my slide, like I had that thing but I couldn't mention that many a times when it comes to LGBTQI services, government takes a stand that this is not so important vis-a-vis the burning points or boiling points, political pressure, other things. These needs of LGBTQ community and particularly transgender community are perceived as not so important thing, but also it's a life. I have presented this paper today based on many incidences which are life-threatening for transgender community. There are so many deaths associated with. I was just talking to Dr. Ratnamala Desai, who is our president for Family Planning Association of India. So we were having a conversation over the deaths during the surgeries, because of surgeries, and because of hormonal therapy as well. We are in a dangerous situation. So we have to have a very good comprehensive service package or model for saving transgenders' life, because every life matters. We are hearing it like leave no one behind. We are already behind. So I urge that Sri Lanka should look into it.
Thank you, Purvi.
Thank you very much for your explanation and answering questions. And the next is from Kalara Pereira and her colleague. And are there any questions from them?
I have a question for you. Based on your research finding, do you have any plan? Because it's very important to do young people engage in such topics, and your insight or whatever your findings need to be incorporated into our actions regarding the young people influence in sexual and reproductive health. I think it's a very important aspect you all have highlighted. So any plans to do some influence in the social media because the research always should lead to actions, isn't it?
Yeah, of course. It's just that the two of us, we are not influencers, but we found this interesting because we thought that it's interesting that across the region, we were looking for influencers who solely focus on SRH, and we could only find them mostly. I mean, we might be wrong, but most of the mainstream influencers who talk about SRH are only from India, which we found to be quite sad actually, because we thought it's such a contemporary topic that needs to be talked. So since we are not influencers ourselves, I think we might have to start from the ground, if we were to start something, but we would really encourage
I think
influencers
from your point of
with
view,
the
you can
reach.
advocate
Yeah.
the others who can do
Exactly.
it, so your research to actions.
Yeah. Those with the reach could perhaps start talking about these things, even if it doesn't need to be exclusively about SRH, because that would be a big step to take. But if they can start from somewhere, I think it would be really good.
Thank you.
I think one of the speakers here also actually, once we ended our conversation, she was like, maybe you guys should start somewhere else, start your own page. So yeah, I guess that's where we have to start, I guess. Yeah. Thank you.
So
Thank you very much.
It's the question time for our last presenter online. If he's online, Abhishek, any burning questions for Abhishek, because we are running behind time? Okay. In absence of any questions, we would conclude the session. Thank you very much for all the presenters. To wrap up everything, I think it's very important to share our experience among each other and learn from each other, especially to combat HIV and STI, sharing our experience among the professionals and among the community workers. It's very important. I think we all learned a lot during this session. Hope we can have more sessions in future as well. Thank you.
This is the time to award certificates. I kindly invite our esteemed guests, our esteemed co-chairs, Dr. Yakandawala and Dr. Geethan to the stage. Miss Nisha Pujari, our first presenter. Dr. Samandika Saparamadu. Praveen Sonauni. R.K. Ravendra Kumar and M.K.N. Pereira, co-presenters. Yes, thank you. Our final presenter is online. We cannot award a certificate to him at the moment. Mr. Abhishek Pratap Sen. Ladies and gentlemen, thank you to all our presenters for their insightful and engaging presentations today. It has been a privilege to learn about the diverse research and innovative ideas shared in this session. I would like to also to extend my gratitude to our esteemed co-chairs, Dr. Akandawala and Dr. Geethani, and the audience members and everyone who made this session possible. Your contribution and support are greatly appreciated. We hope you are continue to engage with ideas discussed today and carry them forward in your work. Have a great evening. Thank you.